All right. Welcome everyone to our weekly Wednesday morning orthopedic surgery grand rounds. Thank you for being here. Thanks for joining on Zoom. Today we have a very special visiting guest speaker. I'll have Dr. Bourbon introduce him. Just as a reminder, tomorrow and Friday are our residency interviews. So make sure, for our residents should be on. Everybody who's interviewing, thanks for participating, and should be a good couple days. So for our introduction, I'll turn it over to Dr. Bourbon.
Thanks, Drew. Okay, and thanks to everybody for participating in our early morning journal club. As Charles pointed out, a little bit earlier than most other journal clubs, certainly in Canada. But we're going to move on to our grand rounds now, and it's my great pleasure to introduce Charles Fisher. Charles has been a friend and a colleague now for over 20 years, and Charles is a professor and head of a combined orthopedic neurosurgical program up at the University of British Columbia in Vancouver. And I've had a chance to visit there a couple of times. Charles has been a real leader in how we think about disorders of the spine, with expertise in areas of oncology, as you heard this morning, as well as trauma. And really, I think some of Charles' most important contributions have been with regard to how we measure outcomes. He's one of the founders, or the founder, really, I think, of the Canadian Orthopedic Study Group, and specifically with focusing on a spine registry for Canada. And I think last night you told us over 50 papers have come out of that registry already, and it's been terrifically productive. And I hope we can do as well with our American Spine Registry, because that's been a terrific source of information. Today, Charles's background, he actually first came to the U.S. To go to college at UCLA. He was captain of the UCLA soccer team. Then he went out to Nova Scotia, where he was in med school at Dalhousie, which I'm probably mispronouncing again, but Dalhousie. And then he went out to the University of British Columbia, where he got a master's in public health, and he's been on a faculty there. And again, now is leading their combined spine and orthopedic program. And today, Charles, is to talk about research overall. And I think this is going to be a topic that follows from Journal Club quite nicely. You've seen the quality of some of the work that Charles has done with randomized studies, as well as registry-based studies. And he's going to talk about how to avoid some epic research failures. So, Charles, thanks for being with us today.
Well, thanks, Sig, and good morning, everybody, again. And appreciate you coming. These are my disclosures, and I will talk about two companies in this talk, just around research, but otherwise, I don't think there's anything there that's a conflict. And this rounds is, and this topic is something that I've sort of put together over a number of years, and it, the title epic, I just threw that in there, but it really depends on, I'm sure everybody in the room has a different opinion on what would be success and what would be failures in research. And when we put this book together with Alex and Jeff, there was a lot of animated discussion around what papers were worthy and what weren't, as far as impactful in spine. And I think there's the same variability in what your goals might be in the world of research, whether you're developing a program, whether you want to publish one high impact paper, or maybe you're not in academics and you just want to understand the research process so that you can do a better job of understanding the literature. So it covers a broad range. And what's shaped my goals and my definition of success and failure is really my experience and education, and my experience both locally, nationally, and internationally. And certainly UCSF has had quite a significant impact. As Sig said, we've been friends for a long time, and he's one of the most brilliant and guys I've met, and fascinating. We have great discussions, not necessarily around medicine, but many other topics. And when I first came down here to David Bradford's lectureship, I got to know David, and I actually got to know him before. And I think the reason we became friends was because the first time I beat him at golf. And he was quite, we were at some AO course there, and he was the guest lecturer. And so we played, and I beat him. And the next day he said, we going to go play again? I go, well, Dr. Bradford, I've got to be on an AO table. I've got to instruct. And he goes, no, you don't. And I didn't realize this, but he has this thing where he grabs your shoulder that Sig told me about later. He grabbed my shoulder and he goes, I'll take care of that. And so I didn't have him. Off we went, the two of us, to play. And, subsequently, I got to know David, and he was a brilliant surgeon and had significant influence on my thinking in orthopedics and research. And as I said, I've known Sig for a long time, and Dean, and this goes way back to the first study group, the spine oncology study group, and some of the studies that we talked about this morning were related to that. And of course, there's been other times, and I've collaborated with a number of the neurosurgical spine surgeons here at UCSF, and Shane and Bobby. And so this group, I don't know if this lecture you guys are going to probably go, we know all that, because you've been a very prolific program, but there's some topics that I think are worth discussing, and you can always learn something, I think. In my local experience at VGH, when I came back, I wasn't at an academic center. I don't know how many of you guys are planning on being in academics, or how many of you are in that? About half, probably, or maybe a little more. The rest in private practice. I was originally not terribly motivated for an academic career. But then there was an opening at Vancouver General Hospital, and Clive Duncan, many of you from the reconstructive world would know Clive, who was our chairman at the time, and he encouraged me to come back, but he said, you're not coming back unless you do your MPH, which, initially kind of pissed me off, but the insight he had was invaluable. And although it was difficult being in practice and getting your master's at the same time, it was well worth doing that. And I have to thank him for that influence. And finally, Marcel Dvorak, who I joined at VGH. It was just the two of us initially who were doing academic work, and Sig knows Marcel. And when we were starting out, it was a mandate for Marcel to do research. And he really influenced me on the importance of it, and that we're in a privileged position with our patients, and we should be doing work to try and make patient care better. And this had a big impact on me as well. So this is kind of the definition I have of research failure. It's not that people don't have the right intentions, but there's a lot of mistakes that are made that can be disheartening and dull your enthusiasm for doing research. So hopefully some of these topics will help you avoid that. So the first is understanding the context of your practice, which I think is really important in deciding your research direction. The second is the importance of funding and how we neglect certain sources of funding, but you need money to do research. So it's really an important aspect of it. The third is, and this is across all vocations, right? Working with compatible people and encouraging them, I think, is a key point. This is really the most important thing of all, the research question. And if you're going to leave one thing today, hopefully you'll leave with the importance of the research question. And then finally, as Sig alluded to, around registries and multi-center research. And there's no excuse for not doing multi-center research now with technology and how easy it is to do. So neglecting the context of your practice. When I first started out, I was super keen because I just finished my MPH, and Marcel had really was enthusiastic about doing research, and most surgeons didn't have their their MPH at that time. So I was unique and I'd learned all about outcomes and objective research, yada, yada. And so I did this paper, it was one of the first ones we published, and using outcomes on DIS. And our center is the tertiary care referral center. So we kind of squeezed DIS in because we're dealing with trauma and other kind of more important things. And but I really liked this paper, and I said, yeah, we should do some more work on this. And Marcel goes, what are you talking about? Like, why would we be doing that? What, you know, there's more important things. And I didn't really understand what he meant. I thought it was an interesting kind of area. And he said, we could do a bunch of things. We've got the potential to study all sorts of different spine pathology. But if we try and do too much, we're not going to be terribly successful, as you know, Steve Jobs has alluded to. And I think it's really important to look at things that matter and things that you can control. And we really couldn't control our elective degenerative population very well because they were all getting displaced. And the smaller centers were doing that. So it wasn't really a good patient population to focus on. And if you look at British Columbia, that's the province where Vancouver is, there's 5 million people there in the province, and all the complex stuff comes to us. And so that's pretty unique. There's no competition amongst hospitals. And we have basically, it just comes to us and we operate. It's a great practice. So there's where the oncology is. The Rick Hansen Institute. Rick was a Christopher Reeve-like individual who was paralyzed in an accident and wheelchair around the world to raise millions of dollars for spinal cord injury research. So trauma, spinal cord injury, oncology made sense. Why not? It's right there. And Brian Kwan was one of our residents at the time, and we got him involved in spinal cord research. He got his PhD and then did a fellowship with Alex Vaccaro back in Philadelphia, and has gone on to be one of the world leaders in a spinal cord injury. And what a perfect setting is our province. He saw everything that was there, so it made sense. And from an oncology perspective, as we talked about this morning, you know, we were able to do a number of papers locally because of our large patient population. And this kind of got us on the map with respect to oncology and allowed us to get into the national and international conversation and started forming some of these groups. So by understanding the context of the practice, where you are and what your patient population's like, you've got to let that shape the research. You know, I've seen a lot of people that'll go away. They did a basic science thing for, you know, fusion and BMP or some other aspect. And they come back and they want to start that at the university they're at, and they're all going, oh, but there's no infrastructure, there's no resources. So, you know, that's probably not the best thing. You can build it, but it's much easier if you kind of look at what you've got and go forward from there. As I mentioned, to get onto that international scene, you really need some winning local. And this is what the oncology world did. And we talked about the various publications that this led to, and the group as Sig talked about. And making that decision of not studying discs and moving on to oncology really had a big impact on my career, and I think has helped a lot of patients. Next thing is funding, and how important this is, because you need a research coordinator when you're starting out. You can't be going through charts and can't be seeing patients. We're very busy as surgeons, and so in order to kind of go beyond a little chart review and a retrospective study, you need help. And I guess, what are the options? You can self-fund, which we did initially starting out, or you can have a supervisor who may have a lab or some money to do work. So those are good. Industry, I think, is very, very important. and a great source of money. Philanthropy, which you guys, I mean, America wrote the book on. You're very good at getting people to donate to foundations and things. And finally, peer review grants, which are one of the most important forms of academic currency. If you get a grant, that's a really big deal. And sometimes local startup grants and then moving on to national and international. Now, the self and the supervisor are pretty standard. And I do want to talk about industry funding, because I've seen this evolution that we go through with different things. And industry funding was something that in the middle of my career, 2008, 10, 11, there was just all this stuff going on that, you know, industry funding was bad. And Lee Goldman, who was the chair of medicine here, I think he went to New York after, but I loved his quote here. It is expensive to do research, and industry should be involved in it, or it just won't happen. And through the early part of this century, it was like, well, we can't have industry involved, and it's just the wrong approach, because research is very, very expensive. And you know, the government funding the peer review grants over time have gotten less and less, to the point now where it's you know, about 60%. So you need to look at these other sources, and certainly in our world, medical device companies can play a role in this. You've just got to be sensible about the way you approach it. And people will say, well, you can't have industry funding because there's all this bias with industry funding. Well, there's going to be bias in research anyway. That's why we have this hierarchy of design, right? You know, from, as we talked about this morning's meta-analysis or systematic reviews of RCTs being at the top, and then you go down. So this is designed to prevent bias, but bias happens. It's going to be there. You just try and minimize it through these processes. Conflict of interest is a different thing. And, you know, again, 2008, 9, 10, there was a big problem. It was out of control, and everybody didn't like Senator Grassley for building a career on this, but it needed to be done. Like, it had to be reeled in a little bit. There had to be more transparency. But like anything, it went to an extreme. And, you know, we really had to look at things and say, you know, how do we make this right again, where industry can be involved? And I remember being very frustrated by it. We did a couple papers looking at more surveys about what the populations thought of research. And I guess they were generally fine with industry doing it, as long as it's transparent and there is acknowledgement and disclosure. We have to be a little careful about sort of this, oh, I'm disclosing it to you, so now it's okay, I can be conflicted again. So there's a balance, but certainly it's something that we need to do and do properly, but we need industry involved in the funding. And this is an example of a study we did with the O-arm, which Shane has been involved in at the outset with O-arm. And we did this with Medtronic, but it was very clear that this was independent, that they had provided a grant, but we had control of the data and collection. It's all outlined there. So in certain situations, I think you need to have industry there. You just need to make sure it's clearly laid out on what's going to happen with the data collection, the analysis, and publication. And industry is key when you're just starting out, because you don't have the track record to attract big grants, and you don't have necessarily your own funding because you're just starting out in practice. So industry is an important way to get started. And I'm not trying to be conflicted with this, but it is something that you need to do. Now, philanthropy, again, Marcel's been very good at, and this is our spinal cord center, the Blue Swan Spinal Cord Center, which he got a donor to help build. As I said before, I think America does an amazing job of getting donations. And Sig was talking to me about some of the donations that have come into UCSF. So I don't really need to talk about the importance of it, but you do need to talk to your patients and get to know them. We're pedaling as fast as we can. And, to get to know your patients and understand where they're from and get them to buy into what you're doing, not only clinically for them, but in a broader sense academically, is important. They don't necessarily have to have massive amounts of money. If you get like 100 patients to donate $1,000, there's ways, but you should look at philanthropy and the foundation takes care of the details. But get patients interested in what you're doing, and they're a good source of funding. And finally, peer review grants. I don't know, how many of you in the room have written a grant before? What do you think of the work to success ratio? I mean, it's terrible. You get demoralized. You spend all this time and then you usually have to fail about 6 or 7 times, and then finally you get it. But if you go in with a good track record, you're much more likely to be successful. And we've been very lucky with Brian Kwan. I don't know if there's anybody in the world with more peer review funding, over $110 million in a relatively young career. Now, some of these are partnerships with centers, mainly in the US, but he is just highly successful with grants. And he has 4 key points. The first, we're going to talk about the research question in a minute, is the importance of the research question. It should be good, obviously. Second is, assume the person reviewing it's not an expert, because they're probably not. They don't know that much about your area. So you've got to make that assumption so that they'll be able to understand. The third thing is, funding agencies don't like to fund and not get a result from the funding. So you need to convince them that you can answer the question and get this done. And that's where your track record is very helpful, which many of us don't have when we start writing grants. So you really need to be able to convince them that you can answer this question and do the work. And then finally, I think it's the most important point. We've, a lot of us in the room review articles for journals, or we might review grants. And we're tired. It's not like you get your little tumbler of scotch and go by the fireplace and, read through this. You got a stack of them and you're just trying to get through them, right? So you really appreciate something that's interesting and easy to read. And these are the 4 points that Brian thinks are the most important in achieving a grant. And this is not rocket science. It's just really practical advice, I think. Third thing is hiring. This again could be across vocations, not just in medicine, not just in academics, but you want to hire the right people. This is our group of 9 at Vancouver General. As Sig said, we're a combined orthopedic and neurosurgical program. And Jim Collins in Good to Great talked about getting the right people on the bus to be successful. And our division head doesn't decide who we hire, we don't. And it is an arduous process when we set out to hire someone. Everybody's involved. It has to be unanimous. Can't have one person who doesn't want that particular person. So we spend a lot of hours making sure we get the right person. And not only within our group here, but within our research team. And we've had failures, but there's nothing worse than a failure. Like, it just causes more problems and you go through the process again. So it's well worth spending the time to hire the right people. And again, we're busy occupation and you don't want to take the hours to do that, but I can tell you it's really, really worthwhile. The second thing is to encourage your research team and your colleagues for higher education. I think, although I didn't want to do my master's, it was the best thing possible for me. So if your researchers want to do PhDs or they want to do masters, I would highly encourage them to do it. And a lot of our group has gone. Nick went to London School of Economics to do his health economics. Tamir's gone to Harvard and did his MPH. So, and it's not just in research and education, there's a lot of things. So I think it's really important to encourage that, and they appreciate that. And often Vanessa, top right there, went and got her PhD and has come back and worked for us and been a brilliant researcher. So encouraging the education is important, and having the right research team who all are part of the process. Often they're authors on papers if they contribute, and I think that's a really important aspect as well. Okay, here's the most important thing of the talk and the research question. And this is something, when I was getting my MPH and Martin Schechter was my instructor on a clinical trials, he kept going, it's all in the question. I'd be going, what the is he talking about? Like, of course you come up with an objective and you do the study, but I had no clue what he actually meant by it. And he was a brilliant guy. He had his PhD in math, and then he went into medicine, and he was actually started the Chaos Group in Vancouver, which was an HIV. And much like San Francisco, Vancouver became a leading HIV research center. And it was because he looked at the context. We had a lot of IVD abusers. We had a large homosexual population. So that was a great place to study HIV early on. And so he was good, and I loved his lectures, but I just couldn't quite understand the question thing. And two other people that have had a significant influence is Alex Vaccaro, who's a spine surgeon in Philadelphia, and he was great at asking practical questions. Like, what do you do in the clinic every day? And you go, shit, I wish I knew the right answer to that. And Alex is brilliant at taking that thing that we debate in clinic and making it into a study. It has really strong rationale. And Jim Weinstein, who is the editor-in-chief for Spine Journal for a long time, who stepped down now, he was always about, like, if you're gonna do a study, do something that's worthwhile, because most of it isn't. I mean, it plays a little bit of a role, but to that point, 10 to 14% of it is really highly impactful. And the one key thing, and I mentioned this morning, is your research question determines your design. Okay, you don't figure out your design first. You figure out your question, and you can spend hours, days working on the question. I'll give you a little bit of a small example here. But this was a study we did early on. I'd just come out and I was all excited. So this is PCA versus PCEA, which is patient-controlled epidural for postoperative pain control. So what do you guys think is the research question here? It has something to do with pain, right? Postoperative pain control. So what do you think? How would you do this study? What would be your research question for this? Don't all answer at once. Perfect. I don't want you to get too far, but you're right. You need some sort of measurement. And you said VAS, right? Okay, so you're talking about this and you go, oh, this is simple. We're going to do a VAS. Okay, so what's the next thing along that? You know what we're going to measure. We're going to use a visual analog scale, 0 to 100, 0 to 10, doesn't matter. We're going to do that. Okay, but so we're going to compare PCEA to PCA, and we're going to use a visual analog scale to do it. Finished? Okay, great. Let's get the study going. And we're not finished yet. Why aren't we finished? So just stay with the VAS. But I didn't want you getting into further stuff. But if we just stay with the VAS, what do you think about that? Is that good? Anybody else, or what? For example, when do you want to do it? Or anybody want to tell me, when do you want to do it? Right, you need your MCID, that's true, but just coming back, like you were a little casual on that, well, 24 hours or 48 hours, like what's gonna make a difference? Like if you're gonna pick up this paper and is it gonna change your practice? You're doing an RCT, this is not easy, I want it to change practice. That's a different question. Okay, post-op day one, yeah. They might be a little groggy. What if they've just mobilized and they're really sore after an hour? Yeah, that's one way to do it. I guess this is just an example of how you can spend a lot of time around something that seemed pretty simple. Oh, we'll just do a VAS, which is the right thing, but when is so important. And what at the end is a patient. So after days, a number of times I left the room saying, wow. We came up and we looked at overall patient satisfaction this is when patients stayed in hospital longer. For 3 days, they usually went home. So we asked them on a visual analog scale, how satisfied were they with their post-operative pain management? We thought that was probably the best, but you could do it a bunch of different ways and so many variables creep into it. And so I just use that example to point out how important it is to spend a lot of time dealing with your question. I've seen so many studies that seem so great, but they didn't pick the right question and they got all this data, it's all registered, and it isn't impactful. The other thing is, and we talked again about this morning, do not be obsessed with RCTs. Like they're exceedingly difficult to do in surgery. Why? You can't blind. There's bias selection. Most patients don't want to go in, and the surgeons will manipulate their patients. When's the learning curve enough? How long, or should you have been doing this operation before you can be a surgeon in the study? Like if it's your second time you've done an MIS TLIF, it's probably not the right time. Is there equipoise? There isn't among the patients. They get on the internet. There's no way I want a fusion. I want an artificial disc. It's just the way it is. And this, I think, is the most important of all. Efficacy is under ideal circumstances. Does it work? Effectiveness is the generalizability, internal, external validity, or other terms for it. And it's very difficult after an RCT because they're so controlled to have generalizability, right? It's just so tightly controlled. Well, what's someone do in another center who doesn't necessarily have that particular system and that particular technique? It's not generalizable. So that's another major issue. And then there's technology change. By the time the study's finished, and this used to happen in the total joint world all the time, by the time they finished the study, svented versus sventless, they weren't using them anymore. It was another type of implant. So there's all this changing evolution. They're very difficult to do, and they cost a lot of money. Now, they're still great for the right research question, but so many people start out with, we're going to do an RCT, and they don't think about what the question is. And people are finally beginning to realize this, and so new types of RCTs are being done within registries, within cohorts, and different ways to recruit patients. And this is having a big difference now in perhaps getting better results from RCTs, because less than 50% of RCTs actually have an impact. We talked about brace, no brace this morning. People just ignored it. Well, I just find that my patients do better with a brace on. Well, great. But you know what? We just spent a bunch of time doing an RCT to show you that it doesn't matter. But you're still going to charge the insurance company. Like, it's crazy, but people don't pay attention to them. Anyway, the take-home message is spend a lot of time getting your research question, make sure you completely understand it. And once that's done, you'll know what design to use. It just writes itself. And that's what Martin Schechter was all about. When you nail the question, everything takes care of itself. The last thing I'll talk about is multi-center research and registry. And multi-center research is so important for two reasons. It gets you the numbers you need quickly, and it's highly generalizable. So it's great. And as I said earlier, there's so much technology now. It's relative, with the EMR and the way we interact, not just amongst ourselves, but across the country. It's very easy to do these studies compared to what it used to be like. So multi-center research is really the way to go. And registries sort of became popular, at least in the spine world in the early 2000s, and most of them failed. And then as the government started to have this Band-Aid about, the importance of pay for, what do you guys call it? Pay for performance and these sorts of monitoring, the professional societies also sort of said, we've got to have these registries. And Sig alluded to the American Spine Registry, which is a national registry that's coming on board, and Steve Glassman, I don't know who else is involved with it. Sig has been a big champion of the process, but getting registries to happen and be successful is very hard, and the majority of them fail. So probably the #1 registry in the history of the world is the Swedish Spine Registry, and I think they have a joint registry, and as part of their practice, they had over, look at this, 64,000 operations, and they hadn't published hardly any papers. Now, is it an administrative registry or is it a research registry? It's a combination of both, but it's a crime if you've got that many surgeries and you haven't at least published something on it. Now they have, but when you think of how long they've been doing it, you would think there'd be, a plethora of publications, but there just hasn't. This was one of the first ones that came out in 2012. So why do they fail? Don't have questions to begin with. Again, coming back to the research question. Try and collect too much data. I've been involved in this. I've had mammoth failures with registries because I didn't know this stuff. Yeah, we should get the diameter of every screw we put in the spine and the length, because we might do a study. So, here you are with 1 billion data points that you're never going to collect. And educating, when you're doing multi-center research, someone in Los Angeles doesn't necessarily know why you're doing it. And so it's really important to educate and tell them what, the context of your practice here, why you want to do this, your involvement from a publication perspective. And one of the best things that we do is get them to be the co-PI or the PI on another research question. So everybody's involved in the process. And you need leadership and, of course, the funding. And here are the essentials. You need a steering committee, and they take care. You got a chairman, you got a steering committee that do all these essential things, determine the direction, and have meetings 3 or 4 times a year to do all this. You need to know what it's about, and usually it's about research questions and ensuring best practice. And you've got to get the education, as I mentioned, and you've got to get adequate funding. So in Canada, we have a unique situation. Going back to my point about context of practice, and I think we have an unprecedented situation because we have one payer for the country. And so there's no competition. We all have wait lists, which isn't good, but so it's there isn't that competitive piece of hospital competition, surgeon competition. We're collaborative. And of course we all have our, differing ideas, but we practice similarly, and our numbers are manageable. We've got great infrastructure now. And what we do is just like what you guys do. It's very generalizable to the world. So I think we're in a very unique situation. And we developed the Canadian Spine Outcomes and Research Network, as Sig alluded to, and this was our steering committee. And we got funding from industry, but they've had no influence on anything we do. And we've educated, and we know why we're doing it. We've got buy-in now from 23 centers across the country, and you can look at our numbers. Early on, it was a bit haphazard, but since about 2016, it's been very good. And obviously, COVID put a dent in things. But large number of patients. We had one RCT and then 3 other prospective cohort studies. That's the largest series in the world with cervical myelopathy now. And all buy-in, not terribly expensive. You know, we have one director of operations for the whole thing who works with the research coordinators at each site, but and a lot has come out of it. And, you know, our only academic currency really is publications. And we've done well at this. And I think the next phase is to get some big grants, because we've established the track record now. So hopefully that'll be the next stage. So those are the 5 ways to avoid epic failures. I'm sure most of you know about them, and but it's important to reinforce them. Some of them are just common sense. But I think if you pay attention to those things, you'll have a successful research program if you're just starting out, or your own research career, or it gives you an idea of, if you're not going into academics, just sort of the various processes that are involved in the research landscape. And the last thing I'll leave you with is this quote, which I think researchers or academicians are really susceptible to. Because we're surgeons, we're kind of consumed with efficiency and moving things along quickly. And I think with research, getting yourself set up properly, getting the right people, and staying on track is really, really important for both you as an individual and for the program that you're involved in. So I'll finish there. Thanks very much.
All right. Thank you, Dr. Fisher. That was excellent. And thank you for traveling down and joining us this morning. We'll take some questions. We'll start with Dr. Lotz.
Thank you. Those are really helpful recommendations. I have a question about, I would add number 6 is, how do you consistently protect time from the clinical enterprise? There's a lot of pressure, obviously, to be productive clinically. So how can you, or do you have strategies for able to protect research time?
Yeah, it's a great question, and one that's really important. And I think depending on where you are determines the model you use. But there has to be some element of protection, whether it's a half day or a whole day, because you'll burn out if you're doing it nights and weekends. Now, I'm not a big fan, although we did do it, of the half-time person who does 50% and 50%. That, in my experience, leads to a bit of bitterness amongst the working group. We have a core of responsibility called surgical OR time and your clinic to get your wait list. We get paid amount of money to do that. And built into that is a half day of academic work. Not everybody in it, you can't have like 9 researchers, right? There's education, there's other things. So our payment method is set up for a core, and then we're given that amount of time. And so it's the responsibility of the division head to ensure that they're doing something outside their core. But you guys have a different payment system, so it's much harder for you. But every center that I know is incentivized research, and they tried to quantify it, has been difficult. So I don't have what's the best thing for your center to do that. But I do agree it has to be protected. We're lucky the way our payment system is that we can do that and it doesn't affect money. So I'm not sure how you incentivize it. Part of it is who you hire too. Like some people are just, they want to do it. But I know like a lot of American centers have incentivized it. I'm not sure, you guys would probably know better than I about how that's worked. I just know it can create some bitterness. You know, you're doing your T10 to the pelvis while I'm having, you know, a steamy cup of coffee and my cinnamon bun, figuring out the research question. It can create a little bit of a problem. But the number one thing, you do have to have some protection.
I'm Mohammed Diab. I'm a pediatric orthopedic surgeon. Thanks for coming all this way and for sticking with what you were telling us, which is making a complex topic accessible to a tired surgeon who may not be an expert. I was having dinner last night with one of our benefactors, and he's not in medicine. And there were others there, and they were talking about things like incrementalism and optimization and all this lingo. But I found that other people in other disciplines are having the same struggle that I think we're having, which is everything's purpose-driven. Everything has to have a good question. Everything has to demonstrate that you can answer the question. Everything has to have ROI and deliverables and productivity and what have you. And they were lamenting controversial figures like Elon Musk, who absolutely want to explode everything. And I think to myself, the miracle of ancient Greece was not purpose-driven. There were no research questions, and they figured things out that are more profound than what we're doing. So the question I have for someone like you, who's so deeply in this world, is there any role for research that isn't like this? And should we be accessing philanthropy for that? Because dollars are scarce, people are busy. You know, we need to reward people for hard work. But is there going to be any space left for, you know, Alexander Fleming leaving the lab and going on holiday and maybe coming up with the most important medical discovery, at least recently? I worry about that because everything is so now programmed. And talking to the people yesterday, it's not just in our world, it's in every, so it seems like in every discipline.
Mohammed, that's a deep question. Yeah, I think we are pedaling as fast as we can, and we are driven by exactly what you're saying. But I probably do some creative thinking when I'm driving my car or I'm fly fishing or not playing golf. But so I think that happens, and I think you need those different thinkers involved in it, and those thinkers should be appreciated. When we have our research meetings, which we have once a month, two of our surgeons are big education. One's a program director, one's on the education piece. Yes, they're at the research meetings, and their ideas are quite insightful because they're not necessarily programmed to be doing everything that we're doing. So I think some cross-pollinization and some respect. Like we don't go, why are you guys here? It's mandatory for them to be here, right? So we get their input. So I think that's a key thing to broaden the thinkers, because not everybody is, you know, a full-blown researcher. And that's why, you know, we borrow business techniques for creative thinking. So I think respecting their opinions and others' opinions is important, but it's a really philosophical thing in some ways. Yeah. Like,
Oh, yeah, sorry. Hi, I'm Alicia. I'm one of the residents. Thank
Hi,
you so
Alicia.
much for your talk.
Yeah.
Question probably not nearly as profound as Dr. Diab's, but I guess my question is, one, what are your recommendations for a resident who's kind of building their career in a short amount of time? And do you think that the pressures to be a prolific resident are appropriate into doing that process? Because the topics that you brought up are vastly important. And there's certain research questions that you can ask that build an incredibly long career, but won't get me a publication before fellowship. And so how do you balance those pieces? And then what are your recommendations for us?
Yeah, I think if you have some people just aren't into research, and that's fine. But if you do want to be in academics, I think that you getting a couple publications before fellowship or during your residency is achievable. I think you'd have to be relatively strategic about it. And usually your mentors help you with that process. I guess if I look at myself, what do I like in a resident? I like that they can write. And, a lot of residents are hesitant. They don't want to hand you a paper because they're worried like it's not going to be any good because they don't really understand it as well as you. So they don't give you the finished project. They give you this thing that you think is going to be really good, but they haven't made it really good because they weren't too sure about it. So I often get disappointed because it would take me longer to edit it than rewrite it in a sense, right? So I think, I love residents being involved, and I'm just very clear with the objectives about it. Make it like you're in university and it's a really important term paper, so that you get that in. And I think your mentors should welcome you to be involved in a project. And it doesn't have to be like the world's greatest question. It's just, to your point, to get you a couple publications. That's probably achievable. Kind of have to nail your butt to a chair to do it, but it is achievable. Do you guys get time to do research? Are you supposed to do a project a year? Is that something like that? And yeah. So what, on average, how many publications might you get in a residency? Am I bringing up stuff that I shouldn't know?
Anywhere from 2 to 15.
Yeah. Yeah, depending on who you're involved with and that sort of thing, right? So I don't think you need to be, if you're being put in charge of a particular question, the clinician you're working with says, what do you think of this? It's a really good question. You should spend time nailing that question and design, and then like I said, the design will take care of itself. So spend some time doing that, but I wouldn't try and conquer the world. You need some publications. You don't really understand a lot of it, right? Gets you to some national meetings and exposure presenting. So I would encourage you to try and do, a couple of papers during your residency. It's hard, but you have to be strategic about the way you do it and get help. Most attendings and researchers are happy they're getting someone to write a paper that gives them another citation as well, right? I don't know if I answered that very well, but I'm happy to talk to you offline.
I just want to thank you for your presentation, your very insightful list, and which we've expanded on already. And so it's been very useful. I think one of the slides that at the beginning that's most impactful that I would underline and encourage, when you showed the group of people, the teams, and how we can't do any of this by ourselves, even whether you're a resident or a young faculty or even a senior researcher. Everybody has teams. We try to emphasize the effectiveness of highly functioning teams and what that does to leverage everybody's success. And I'm sure that's been the case in your own experience as well, because you mentioned teams and everything you did.
Oh, absolutely. And, it comes back to your question a little bit too. Hopefully you've got a research coordinator who helps you do that. And they play such a large role, especially the ones that you've managed to retain. And that's why encouraging them to get their masters and stuff is so helpful. But you're so bang on. You can't do any of this without the team and from the surgeons down, because and someone's got to operate, right? not everybody's at the American Academy meeting. You can't, someone has to stay home, which is
You
part
know,
of the team.
One other thing I wanted to mention, get your take on, we talk about how do clinicians carve out time, okay? Basic scientists have all the time in the world, okay? I don't think that's a fair characterization exactly. And I know I'm not putting words in your mouth. You didn't say exactly that, but sometimes that's what people think. And the reality is clinicians have a huge amount of demands on their time, but they also have a way to create revenue to support themselves to do other things. Whereas a basic science person who's in a lab has to get peer funding or institutional funding. There is no other source. So the pressure is quite high on those individuals to produce. So there's tensions, there's stresses, there's demands on time for both groups. But and I don't know how you, and it's probably not even necessary to compare one to the other, but there are stresses for both and opportunities for both. Maybe one has the luxury of time, the other has the luxury of resources. How do you want to mix that up?
Yeah, I didn't go into that, but it's exceedingly stressful. Your whole lab relying on you getting that grant, and your postdocs or your students. So it's highly stressful and a completely different world to the one we're used to. And because even if we don't do any research, we can still operate and make money. So it is difficult. I think understanding exactly what you just alluded to is really important. We work with the biomechanics group at UBC, which is a big group, and they're in a totally different way because they're really grant funded. So I think respect for that and understanding. I mean, my cinnamon bun comment was just about the way surgeons look at that, right? But I think sharing and working with those groups is enlightening when you see the basic scientists and understanding as a surgeon what they're going through. And you've remarked on the funding piece is important. And they value your input so much too, because they're not in the OR. They don't understand why that happens. So it's again, I think a collaborative process and understanding, sharing.
Well, Charles, thanks so much for sharing your experience with research, your success. I think part of the message you heard is that data is central to this as well. That's where multi-center study groups come in. That's where registries come in. And maybe the last sentence is when you're thinking about a project, especially when you got limited time as a resident, make sure there's some data there already. To that end, Charles, thanks for sharing all of your experience. Thanks everybody for coming today. We had over 70 people intermittently on the Zoom. So thanks to all the Zoom participation. And maybe we'll have just a few minutes if people want to ask Charles questions individually. Charles will be here for just a few more minutes. We'll move on to our basic science. So thanks again for everybody for coming.
Thanks very much.